I'm David Fleischer. I'm a gastroenterologist at Mayo Clinic, Arizona. I'd like to talk to you a little bit about our article, which is soon to be published in Gastrointestinal Endoscopy. It's entitled Intestinal Metaplasia of the Cardia, and is there a difference in patients who have Barrett's and those that do not have Barrett's? Well, Barrett's is really only important for the most part because it's the main risk factor for esophageal adenocarcinoma. And esophageal adenocarcinoma is the fastest growing type of cancer in the United States and the Western world. So that's really why Barrett's and reflux are so important. And the definition of Barrett's, as a gastroenterology audience would know, is defined as having intestinal metaplasia of the esophagus, and that's well agreed on, although in some of the guidelines they say that it has to be greater than 1 centimeter. So you have a well accepted definition of Barrett's, which is intestinal metaplasia of the esophagus, but our study focuses on intestinal metaplasia of the gastric cardia. So because it's the gastric cardia, it's in the stomach, it's not the esophagus, so it wouldn't meet the definition of Barrett's, but there is some controversy and some differences of opinion about how important it is to have intestinal metaplasia of the cardia. For example, because there's some difference of opinion, in those cases it's very common for societies, in this case GI societies, to write guidelines. And the different societies have written guidelines, but the most recent one, to which many of us adhere, are the 2016 American College of Gastroenterology guideline on Barrett's. And in that they say a couple of things. They say that intestinal metaplasia of the cardia is not a risk factor for esophageal adenocarcinoma. They also say in this area where the top of the stomach meets the bottom of the esophagogastric junction, that biopsies there really are not appropriate, certainly not in the cardia, and even if you have a small section of what appears to be Barrett's endoscopically in the esophagus. So that's what they've defined, and that's what seems to be important. I do have a problem because if you just think about biologic systems, it's hard for me to believe that if you have Barrett's and it's just above the esophagogastric junction, it's in the tubular esophagus, and you have intestinal metaplasia, that literally millimeters or centimeters just below that in the gastric cardia, if you find the same intestinal metaplasia, it doesn't make sense to me that in a biologic system there would be such a clear cutoff when both of them show the same histology. And there just hasn't been that much work about the intestinal metaplasia in the cardia. In fact, a lot of the studies are quoted in the guidelines are studies from 75 years ago, or studies from 17 years ago. And so if it's older things, it may be that with new technology and new evaluation systems, there's some importance. So our study asked the question, number one, is the intestinal metaplasia of cardia important, and is there a difference between people who have Barrett's, so they have intestinal metaplasia of the esophagus, and those that don't have Barrett's? Well, you asked what is the gastric cardia, and that is a heck of a question. You would think it'd be pretty straightforward. Everyone would agree that if the stomach is divided into different anatomical segments, that there's a fundus, there's a body, there's an antrum, and there's a pyloric area. The most proximal part of the stomach is referred to as a cardia, and there have been debates and many papers written on both sides of the topic suggesting, well, it may be congenital and you have it since birth. Some of those studies depend on pediatric studies and autopsies of babies who didn't live or died at a young age. And then there's others who take biopsies from this area later on and don't think that it appears. It's also a bit of a discussion for pathologists, because in the gastric cardia, when you look at it endoscopically, you really define it as the most proximal area of the gastric fold. So endoscopically, you don't see a big red line or a neon sign that says cardia. You just know you're at the proximal part of the stomach, and you biopsy there. And so that's called the cardia endoscopically. To define it, pathologists would say you have to have cardiac mucosa there. And so when people have biopsied that area, sometimes it's shown up, sometimes it hasn't shown up, and so that's really led to a discussion of what is the gastric cardia, and that's, again, what we looked at in this study. As I mentioned when I was referring to some of those other articles, there's an issue if everyone has that, is it there, is it present at birth? And one of the theories that's the most popular today is that the gastric cardia, like Barrett's, is caused by reflux. So in the study that we did, when we took all of the patients, 81% of those had a gastric cardia confirmed by biopsy when biopsies were taken in the most proximal part of the stomach. So that's one of the findings of the study. The other is we divided the patients into those who had Barrett's and those that did not have Barrett's, and in those patients that had Barrett's, there was a higher frequency of having intestinal metaplasia of the cardia, again, which may push you to the consideration that it may be related to reflux, as Barrett's is related to reflux. One of the curiosities about Barrett's is that, number one, whatever length of Barrett's a patient has when they're first diagnosed, that length doesn't change. So if I see a patient who's had reflux, and more typically, since 85% of patients with Barrett's are Caucasian males, so if I see a 62-year-old male who comes in and has reflux symptoms, we would want to do an endoscopy on him, particularly if he were obese and smoked cigarettes. Those are some of the risk factors for Barrett's. And if you found Barrett's in him and it was 4 centimeters, for the rest of his endoscopic days, he would have a 4-centimeter length of Barrett's. It never changes the length. What does change is that if Barrett's is intestinal metaplasia of the esophagus, it's only important is if it progresses to esophageal adenocarcinoma. And there is a stepwise progression which shows that people begin with intestinal metaplasia, then they go to low-grade dysplasia, then they go to high-grade dysplasia before they get esophageal adenocarcinoma. So in patients with Barrett's, the management is generally dependent on whether or not they have dysplasia, which is a step beyond basic Barrett's, on the way to adenocarcinoma, and to some extent, the longer the Barrett's is, the more risk they are. So intestinal metaplasia is important in Barrett's because it is what Barrett's is, and it can progress. With regard to the cardia, things are less clear, but what we did find is you're more apt to have intestinal metaplasia of the cardia rather than a cardia without intestinal metaplasia. You can just have cardiac cells and make it cardia, but to have intestinal metaplasia, you have these intestinal cells. And what we found is that of the 289 patients in our study who had Barrett's, when we biopsied the cardia, 17% of those had intestinal metaplasia. And when we looked at the 173 who did not have Barrett's, only 7% of the patients had intestinal metaplasia of the cardia. And this is, again, getting back to if Barrett's is important, is intestinal metaplasia of the cardia important, and should you even biopsy the cardia, because the current recommendations that I referred to previously say that there's not really a need to biopsy the cardia, and what we're raising the possibility is that it could be important to do that. Yeah, I think when any study is published, it's commonplace for the authors who are making the points to say, are there limitations to their study? It's seldom that any study is perfect. And since the gold standard would be considered a randomized controlled trial, in our study wasn't. It was a prospective study where we looked at two groups of patients. Certainly one of the considerations is what are the two groups that you're comparing. So in the first group, we are comparing patients who had Barrett's, and then we look at the biopsies from the proximal stomach. So that's the Barrett's group, which we show has an increased frequency of intestinal metaplasia of the cardia. In a perfect study, you would compare that to a control group. That's a group that doesn't have symptoms of esophageal reflux or other digestive symptoms. In our study, again, we were going to take patients who we knew had Barrett's and those we didn't know had Barrett's, but many of the patients who did not have Barrett's had symptoms of esophageal reflux or difficulty swallowing or some upper digestive symptom. So any reviewer should say to you, Dr. Fleischer, that's not really a control group. Our rebuttal was that it would be raise some ethical concerns if you said to people who don't have any GI symptoms, and again, not everybody thankfully not everybody who doesn't have upper GI symptoms gets an upper endoscopy, but number one, for those who are getting with something that didn't relate to reflux, it'd be hard to justify biopsying an area when there's no likelihood that there would be a problem. And again, getting through that through an IRB, they may say, how can you take normal controls and do this? So we didn't do that, and again, we appreciate that limitation. The largest limitation to our study was the fact that when this was begun, we tried to do things to have the data be as clear as possible. So it was done, all the biopsies were done by one gastroenterologist, and that was me. I'm labeled as an experienced gastroenterologist to some extent because I have a lot of experience, to some extent because I'm an old guy, but that's the experience is. And I've done work with esophageal diseases for my entire career. So that's one of the things we did to minimize the variation. Also, since I was the only one taking biopsies, I could be very precise as to where the biopsies were taken. I did not want to biopsy the squamocolumnar junction. That would raise a lot of questions. I didn't want to biopsy the area above the in the esophagus. I was looking to biopsy an area that was within 1 centimeter of the folds. So having a single endoscopist do that was of some benefit. But when the biopsies were done, even though they were all sent to one pathologist and we counted the number of fragments, when we look back upon it, we did not have a standardized protocol, so there were actually more biopsies taken in the group that had Barrett's than in the group that didn't, and that would make a difference in the interpretation. So that's the two main limitations which we believe are important. I think the four main takeaways of the study are as follows. Number one, that we think cardiac mucosa is commonly found. In this group, it was found in 81% of patients, and we believe that it's related to reflux and it's not congenital and that not everybody has it, but you're more apt to have it if you have reflux. We also believe that it's more common to have intestinal metaplasia of the cardia if you have Barrett's than if you don't have Barrett's, so that we think that patients that have Barrett's should have biopsies taken from the cardia, which is definitely not done routinely, but we would suggest that that be done routinely. The third point is a lot of times when people refer to this whole area, they'll often say, we're going to take a biopsy from the squamocolumnar junction. And again, that's where the squamous cells of the esophagus meet the columnar cells of the stomach. It's and the squamocolumnar junction and the esophagogastric junction are the same unless someone has Barrett's, so that that area is referred to sometimes as the SC junction, sometimes the EG junction. But where they meet, there's a common description to call that the Z line. And the reason it's the Z as the letter is chosen is because that line is seldom straight, but more often has a Z-like appearance. And my experience has been that in a lot of publications, a lot of doctors, when they speak at meetings, even the most important doctors in our field, use the term irregular Z-line. And we think that that term adds to confusion in the area because if you're not sure whether this intestinal metaplasia cardia, short segment Barrett's, normal, you say irregular Z-line, when everybody who does endoscopy knows that most of the time that line is Z in shape. So it's just a term that I find confusing. And then really the final point we would make, we would understand if someone said, we see your study, let us think about it, and that's really the main point we wanted to get out, that we think dialogue should occur in the area rather than things being dogmatic. But the next step would be that if a randomized study were done and it addressed the limitations of our study, and if that information came up with information was similar to ours in a study that was better designed and took away some of the flaws, then we really think there would be a need to change some of the recommendations that are in a guideline. So those are the four main takeaway points. So in summary, I'd say the main purpose of this is to get this information out. We're pleased to have the opportunity from gastrointestinal endoscopy to present this information, and they have contact information so the authors can be reached. Thank you.